Welcome to QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic this month is sponsored by Sanofi. We're talking about PMR, make room for PMR. I want to give you a QD Clinic on what I think are the lessons I've heard by listening to the Tuesday Nite Rheumatology sessions every Tuesday night, 7 p.m. 1 hour webinars where we've had the best of folks talking about diagnosis, steroids, steroid sparing, and next week talking about controversies. Here are some top lessons that I've learned. I want to begin with Stephen Paget's wonderful quote from the first TNR, which was, giving steroids to PMR is like giving spinach to Popeye. I thought it was brilliant, and it's so true. I've given steroids to PMR patients. They come back, they want to just hug me, kiss me. I mean, they're just so quickly happy and dramatically better. But the point about that is it's memorable, it's impactful, but you know what? It doesn't make the criterion for diagnosis. When the ACR and EULAR folks in 2015 were devising their guidelines and criteria, they considered this, but they found it to be a subjective, unquantifiable, and therefore unmeasurable tool that you could not ascribe a predictive value to. Everyone agreed it's something we like to see. At the same time, it's not always seen, and not seeing it really shouldn't exclude the diagnosis. Number 2 comes from Richard Conway, who in our steroids and PMR discussion, there was a lot of talk amongst our great panelists about the variety of weaning regimens with steroids. And it's kind of all over the map, I must say. It's probably shorter than you think. It's only a few weeks at each dose, not a few months. Everyone seems to agree 15 milligrams is the starting dose. Some people like 12.5, but generally 15. And I like Richard's, make it easy for the patient. Let's make changes in monthly increments. 15 milligrams a month, then 12.5 for a month, then 10 for a month. And then after that, you're going to decide if it's 2.5 a month or 1 milligram a month to take them down. It really makes the most amount of steps. And I think that I thought was smart. The question is, next, when would you use a steroid sparing agent? And I think everyone sort of agreed on 2 parameters. 1, 2 attempts at steroid weaning that were unsuccessful. And the second, the need for higher than expected doses of steroids, because that just portends a long, prolonged course, doses you don't want, steroid effects you don't want to live with. Second issue on steroid-sparing drugs is that you, the rheumatologist, and the panelists all agree, almost like 95% of the time, if you're going to use a steroid-sparing drug, start with methotrexate. We had some discussion about leflunomide. No concrete data, this trial in process. But we do have new drugs. Sarilumab, an IL-6 inhibitor, is approved. Most really felt you should go through methotrexate before you went to sarilumab. That's, I think, a smart issue. The next issue I thought was, when would you do imaging in PMR? Imaging is part of the diagnosis for GCA, but not necessarily required for PMR. But when would you do imaging? And I think that we heard when it's atypical cases or when there's a GCA-like symptomatology, jaw claudication, ischemic symptoms like vision, weight loss, FUO, these are the sort of things. And my last takeaway that I learned this month from listening to Tuesday Nite Rheumatology was sed rate and CRP. You know what? Not always elevated, and if not elevated, doesn't exclude the diagnosis. But it doesn't let you get away with an easier diagnosis either. Now, you got to double down on all the other features that need to be characteristic and requisite. Or now go a step further and start doing imaging, right? Doing imaging of the shoulders and the hips, maybe even doing imaging of the temporal arteries. But the idea is that saturate and CRP can still be normal or lowish and make a diagnosis, but you need to be certain by all other parameters. That's it for QD Clinic. Tune in for more of these throughout the month.